So what to do? Patient safety has to come first. Luckily, it's very rare. It's really very unusual for a patient's life to be put on the line during a consultation that you're watching. But like all of those rare events, if it happens to you, then of course you step up to it and you're going to act. It's much more common that there'll be moderately serious things, and you'll need to make a judgment call as to, do I interrupt now, or can we discuss this at the end of the consultation? And discussing at the end is actually very, very helpful role play, because let's face it, lots of us have the patient walk out the door and you see them pulling off in their car and they're driving away and you think, oh, I meant to do such and such with them. If it's really important, you ring them up and you get them back, or you deal with it. So it's not an unreasonable modelling process to show the registrar how to deal with something that you've had an afterthought.
It is really important to try and continue to keep your purpose for being there with respect to the learning of the registrar, and so we have to minimise as much as we possibly can any intervention into patient care, because it might seem that it will adjust the content learning for the registrar, but in fact what it does is undermine their process learning quite a lot, and even their confidence in what they're doing. So, it might be possible to, at the end of the consult when it's finished, to actually immediately say to that registrar, look, I'm really concerned that you've missed the possibility this lady could have been suffering unstable angina. Do you think that's something that we can follow up on now? And enact the process of actually getting the patient into the nursing treatment room or wherever and doing an ECG, etc. It's never lost, but if you can possibly do it without actually interrupting that consult, I think it's most safe for that registrar.
So that's a very good question. What becomes of the feedback forms? They're scanned, and each registrar has what's called a profile, or just a file of their progress, and they're kept there. And let's talk for a moment. You might be thinking of if things are not going so well. Is that where you're leading? Yeah. On your form, if you can bear to have a look at the very back page of that little handout you were given. Sorry, it's not the very back page, it's the page with the blue on two sides. You had it before. It'll ask you, is the registrar safe, unsafe? Does this need to be discussed with the Director of Education? Question. When you do the acronym form, you'll also get other opportunity to write in it, or I'll write it on my cover letter, that the patient's safe. Yeah.
Registrar.
The registrars. The patient, we hope, is safe. The registrar's safe too. Yeah. So we take a lot of notice of ECT visits, and you might have noticed if there's a registrar in the clinic, often one of the first things we'll do is say, let's do an extra ECT visit, or let's do an early visit. So at the interview process, and we're thinking, I wonder how this person's going to settle in, one of the quickest ways for us to work out is we do an ECT visit, we get to talk with the supervisors and hear from them, we get to directly observe what's going on behind the closed doors.
Just one other comment. Just one other thing about preparing. It's important that the patients are aware there's another doctor in the room, and usually the practices are pretty good at doing that, but it is helpful to just jog the memory of the doctor when you're visiting to say that another doctor is visiting as part of my training, is that okay? Or sometimes it's a colleague is sitting in the room, and we hope that that's all right with you as a matter of consent for the patient on the way in.